It's a good thing. Now, Dr. Danish Sami, he will talk about permissive hypotensive. No, please.
Thank you, Assad. Right, I think it's illogical to argue a fact which is established by ATLS principles, But, in the previous lectures today, we heard about it, that it's good to question them. And I thought your talk was, it sounded more like a no talk rather than a yes talk, so let me try convincing you that it's a good thing. Fluid resuscitation trauma goes back, 1950s and 60s, and I found two papers written in that time period when they were saying, okay, if you give fluid, it's good. Okay, so the discussion goes back around about more than 50 years now. But one of the good papers that came out was Bickel. I think it's a bit unfair not to mention that what they were looking was back in 1994, and this was published in the New England Journal of Medicine, that if you have immediate versus delayed fluid resuscitation for hypotensive patients in penetrating torso injuries, the patients who have had delayed fluid resuscitation, they do better. Survival to discharge is better if you got a delayed resuscitation in hypotensive patients. And again, it wouldn't do justice if you don't mention Karim Barohi in this. Karim has been a fantastic trauma surgeon working in Royal London, and he's produced this fantastic debate in the last 15 years in trauma circles about traumatic coagulopathy and the effects that we had. And we have learned a lot about trauma resuscitation from his work. And he introduced us to the concept of what acute traumatic coagulopathy is. That if you give fluid, initially this paper defined that there is something going on in a trauma patient, they lose their coagulopathy, and there is something going wrong with their coagulation profile. So that was the first defining paper that came out from Royal London. But the key principles in permissive hypotension is that basically you are allowing, in simple terms, you're allowing your patient to become hypotensive because you don't want to pop the clot. We applied those principles in aortic aneurysms. We know that if we give them more fluid, the clot will pop, and the aneurysm will pop. But the volume resuscitation should be minimal. That's what they are saying. Keep the subnormal blood pressure itself is not the target. It's basically stopping the bleeding is the target. So it doesn't matter where your blood pressure is, as long as your patient is clinically getting better, you're fine. And the management should be more towards surgical control of the life-threatening injuries rather than just trying to manage blood pressure in the emergency department. Earlier today, we learned that systolic blood pressure is useless. Why are you trying to chase something which is ridiculous? We learned about the shock index earlier on. And we all remember from our ATLS teachings that, this table of shock, 1, 2, 3, 4, and we were all told, don't just rely on the blood pressure, look for other signs of shock. So why we are kind of looking just for the blood pressure to treat the patient, I don't understand that. But one of the important, I think, things need to come out from this discussion with permissive hypotension is that don't be fooled by keeping the blood pressure low. The permissive hypotension may be interpreted as a permission to ignore hypotension of all other causes. You still need to look for pericardial tamponade. You need to look for tension pneumothorax. So if your blood pressure of the patient is low, don't think that that is the physiology that you're going to drive this patient on. You still want to rule out other life-threatening injuries. And yes, it's not applicable to all the patients. There are certain patients, you don't want to reduce the blood pressure. We all have gone through this, central perfusion pressure equal to mean arterial pressure minus ICP. So if you reduce the mean arterial pressure in a patient with a head injury, you will lose, your patient with a head injury. So this is not applicable to the traumatic head injuries. Now, ATLS, there has been such a lot to talk about ATLS, and emergency physicians, you do feel that the goalpost is changing more or less every edition they're producing. The initial fluid resuscitation, they said, well, you're going to give 2 liters. They reduced from 2 liters to 1 liter. In the 9th edition, that's the statement that I got from the ATLS, and they were saying that in penetrating trauma with hemorrhage, delaying aggressive fluid restriction until definitive control may prevent additional bleeding. So that is the statement that they've given it. But in the 10th edition, which is going to come out next year, they are going to be talking about judicious fluid resuscitation. So they're just gone 180 degrees now. That please don't do permissive hypotension, basically. That's what they are saying now. So in the next few years, the discussion is going back. So the pendulum has swung back to the other side now that, you should give more resuscitation and the evidence will come out of that. So the bottom line is, jury's still out. I think clinically, you have to be cautious about permissive hypotension. As my colleague said, don't ignore the blood pressure. It's not a very comfortable feeling, and look for the other causes.